no worries. Two, Paul will be starting us off.
Yeah.
Yes, he'll be doing the session first, then I'll finish with the session on gender and SRHR.
So I'll just call on Mr. Paul Musumba to take us through the first session. Paul, if you are ready.
Yeah, thanks, Mr. Austin. And in fact, it's such a good morning. Though a bit rainy and chilly here in Nairobi, but I'm delighted to join all of you this morning just to share and deliberate on matters SRH. SRH, I think, is very, very important to all of us and is a very interesting topic. So let's all have our minds open. Let's have an open discussion. And we're here to learn from one another. Actually, whatever we're going to talk about this morning are not unique things to us. I think these are common things, but just a matter of sharing ideas and getting to know from one another what is important and what we need to do to help our adolescents and young people get SRH services. So I'll do a presentation. I'll cover two sessions. That is on referrals and linkages for SRH services, as well as designing effective designing and implementation of effective or successful SRH packages. So let me just a few seconds as I share my presentation, please. Sorry, I'm just getting a notification that the host has disabled screen sharing. So I don't know, please, if you can enable that so that I can present. Austin?
Okay. Hi, Dave.
Now share, Paul. Paul, now you can share. I've made you a co-host. You can share your screen now.
Okay, I'm sharing. So kindly just confirm once you're able to see it. Is it showing?
Not yet.
Not yet, Mr.
Okay.
Paul. It's okay.
Yes.
It's okay, you're able to see it, huh?
Yeah.
Okay, so welcome guys, and I think as earlier introduced, my name is Paul Musumba. I do coordinate community mobilization liaison with Maristops Kenya. I'm a community health specialist focusing on SRH, mass of family planning, and HIV and AIDS with both adults and young people. Having worked with Maristops, this is my 7th year in Maristops. And also a number of other organizations focusing on SRH, both at community and clinical setups. So as I said, these are the two sessions that I'm going to facilitate today. That is designing, planning, implementing, and evaluation of effective SRH interventions. And then later on, I'll take us also through on referral and linkages for SRH services. So as we move along, in case you happen to have any question, or maybe if you realize that I'm moving a bit faster, kindly just interject at any time and I'll be glad to help out. So just to start us off and talk about successful SRH intervention. And this is just a quote from the World Health Organization. It says that when we talk about appropriate adolescent sexual health, adolescent sexual reproductive health intervention, such a package should be provided by provided at a well-stocked and welcoming facility and other entry points, of course, with competent staff and in collaboration with community stakeholders and adolescents themselves. So it means that for us to qualify, or for any package to qualify as a successful SRH package, it must be provided in a setup, and the setup here we're talking about a health facility that is well stocked and has competent staff. And of course, as we do all this, we must be working in collaboration with the community stakeholders and adolescents themselves. Because, in matters SRH, adolescents are the major stakeholders in this. They are the key target and at the same time, the major stakeholders. Key target as in beneficiaries, because they are the people we are targeting for these services. Talking about the interventional packages, we'll focus on 3. The first one, we can have a package that is designed for schools. And here, basically we're talking about primary, that is upper and secondary schools. And in schools here, mostly we focus on provision of SRH information, mainly provision of information. However, there are also those adolescents in schools, particularly secondary schools, that might be in need of other services, SRH services, for example, HIV, STIs, and even contraceptives. Those can be discussed later. In health facilities, mostly here, we're talking about, in schools also, there's that aspect of life skills training. So just besides offering information, that is, for example, targeting prevention of early or teenage pregnancies, prevention of infection, that is HIV and STIs, we can also have a package that aims at equipping these adolescents or young boys and girls with proper skills, what we call the life skills training. In health facilities, this focuses on provision of services, that is STIs treatment, prevention, or testing, not family planning, but offering contraceptives, that is for prevention of pregnancies, and then community outreaches. So there are also cases whereby we have those adolescent or youth outreaches in communities that focus on provision of information as well as services at the same time. So in terms of interventional packages that we're talking about here, we can focus on these 3, that's the schools, health facilities, and community outreaches. Now, talking about characteristics, talking about successful SRH interventions, we have a few characteristics that define a successful or an effective adolescent sexual reproductive health intervention. And there are 5 main characteristics here that I'm going to talk about. First is that these interventions should be adolescent friendly. Number 2, there should be that aspect of training and capacity building of the staff. Staff here, we are referring to the service providers or the people who are passing across that information to the adolescents. Number 3 is facility-based services. Here we look at the nature of services being offered at the facility, as well as some structural formations at that facility. 4th characteristic is on community-based services and outreach platforms. We're going to discuss this in detail as we move on. And then finally is a multi-sectoral linkages and referral pathways. Let's look at the community-based outreaches and outreach platforms, community-based services and outreach platforms. What you're talking about here is, first, for example, we need to be engaging adolescents and youth as first responders. You know, when we are designing these interventional packages, we must at all times put in our minds the target. What are the primary beneficiaries of these services? So therefore, we must embrace that participatory approach whereby the adolescents themselves or the youth are engaged actively. And because we're talking about community-based services and outreach platforms, we must therefore also consider the local organizations and youth-led organizations. That, for example, anytime we go to a certain region to implement these interventions, we must do some proper mapping on the ground to ensure that our services and even the aspect of mobilization is led by organizations that are locally based and also youth-led. I want to give an example like Maristops. For a number of years, we've been having adolescent-focused interventions. I've seen some of the participants here must be fully aware of our, for example, the Future Fab program, the C4C outreaches, the youth outreaches that we've been running in a number of places, for example, Kisumu, in Nyanza. And we realized that most of the times we used to go to run those outreaches. They were being led by the local organizations or youth groups on the ground. And then also now, another aspect under this characteristic is on community health. Which services are we talking about here? That the services being provided under this intervention must be services that are beneficial to that community, the community of adolescents and the youth in that area. The last aspect here is about communication, media, and technology. I think right now, you cannot successfully implement an adolescent or youth-focused intervention if you're not considering technology. Most of the young people currently are more present and more active on social media. And that's why you realize that today, if you focus so much, for example, on using posters, the physical posters, to put across information, you might not be able to reach out to as many adolescents as possible, compared to whereby you are posting that poster or that message via WhatsApp or whatever, or Facebook. So therefore, it means that we have to be also considerate of the changing times, and for us to be able to communicate effectively and reach out to as many as possible adolescents, then we must consider aspects of technology, embrace social media, and even also talking about the media. For example, if you talk about the radio, for example, we must also consider which radio stations are more, which radio stations are more liked or more listened to by adolescents, so that whenever you want to pass across a message, then you'll be able to effectively reach out to the targeted audience. On training and capacity building, we all know that the way an adolescent is treated for the first time in a facility will determine whether that adolescent will come back for another service at that facility or not, or whether they are going to refer their fellow adolescents or friends to come for services at that facility. Satisfied clients is a very, very key aspect in terms of mobilization and client referrals. If you're able to treat a client today and he or she goes home very satisfied and happy with the service, then that client will be able to refer more other clients for services to that facility. So we're saying that adolescents sometimes may feel hesitant to seek out SRH services just because of what? The stigma and the cultural factors surrounding SRH, or maybe from lack of understanding or knowledge of their bodies or needs. That sometimes people suffer in ignorance. We might be having a problem, but we are not so much aware of it. We've not been informed, we've not been given information or sensitized about that issue. And also, we've not been given information in terms of where we can get assistance.
You are reading it up, Panda Ju.
Sorry? Is it a question or just a comment? Okay.
My apologies.
Okay. So stigma and cultural factors surrounding SRH. You know, sexual reproductive health services, still many people in the community, in the society, are not so free to talk about them openly, sometimes because of our cultural backgrounds and also stigma. The number of cases whereby you find that, for example, a 17 or 16-year-old girl walks into a facility to seek for what? Say, for example, counseling on contraception. But because of that cultural background or personal values of the service providers, they look at her as what? You are so young to start discussing matters sex. So you're not supposed to be seeking for these services. So that in the end is going to stigmatize that girl and might not be able to freely walk into another facility to seek such services. So therefore saying that it's very important for providers and even the community health workers and even the members of the team, yeah, or even the youth champions in the community, that we need to work together to create a welcoming environment for adolescents to receive high quality, private and confidential care. Let's not be led by our values, and let's not allow our personal values to act as barriers, as a hindrance towards other people getting services that they may need. Whatever I value, whatever my personal values, should not act as a hindrance to you getting services that are beneficial to you. We have different backgrounds. My family, my Christian, my community, or my cultural background is different from the people that I might be serving. And therefore, I should not make use of my values to prevent other people from accessing those services. In terms of facility-based staff, or facility-based services, this is another characteristic of effective or successful SRH interventions. So you're saying that communication between the team and the facility in the adolescents plays a very, very major role. And it sets a precedence for further engagement and whether they return for SRH information or services. As I mentioned before, if you take an example of, say, a staff at a facility who negatively receives a young girl coming in for services, that is going to act as a deterrence. It will be a turn-off for that girl in terms of approaching that facility for services. So you're saying that we need to encourage staff or team members at the facility to be more welcoming, more encouraging, and be more positive towards adolescents getting services. Not a case of, for example, a young boy coming in with an STI infection seeking services. But instead of that boy being received positively and warmly at the facility, he is being reprimanded and being blamed for having been reckless. This is, for example, a 15-year-old comes with an infection, a gonorrhea, for example. And then instead of welcoming them, you're telling them, oh, I mean, at 15 years and you're already having sex? So it's like you're blaming the boy. So we're saying that communication between the staff at the facility and the adolescents is a major role, and it determines whether they come back for services or not. So we're saying that the facility should have a diverse range of providers and support staff, including a range of ages and gender. The services, or there are some people who may feel more comfortable being attended to by someone or a service provider of their own gender, of their own gender or sex. There are girls who would be more comfortable being attended to by female staff, or vice versa. Or even boys who would feel more comfortable being attended to by male staff. But at the same time, there are also boys who may feel more comfortable being attended to by female staff. So we're saying that we need to have a range of ages and genders. In terms of communication, you realize that most of the times that adolescents may feel more comfortable speaking to a provider of their own age. In some cases, you realize that some may feel not so much comfortable talking to, say, a nurse or service provider who is of their mother's age. Because of what? That fear of being judged. However, this may not be the case in all the places. There are some places you go to and some adolescents or young girls feel comfortable talking to an elderly service provider. So it varies. So just saying that we need to have a mix of that so that we don't end up with a situation whereby a facility is just full of what? Aged or adult service providers, which might be a deterrence to some adolescents coming in for services.
Well, could you please move your slide because we are not seeing any movement.
Oh, it's not moving.
It's not moving, yeah. And actually, it's not even on PowerPoint mode.
Mine is on PowerPoint.
It's not on the overall scale, like in large scale, yeah. I don't
Presentation.
know. Presentation mode, yeah.
Okay, maybe let me try to reshare again, because on my end it's just okay.
It wasn't moving. Just confirm.
Okay. Sorry for that. Let me just try to work it out again. Is it now okay?
Yes, now it's okay. Confirm.
Okay. Is it now moving on your end?
There is the multi-sectoral linkages and referral pathways.
Okay. So for multi-sectoral linkages and referral pathways, here we're about providing multi-sectoral responses that incorporate SRH training and relevant activities across sectors required to address the whole person. I think that a number of times also we realize that it works more better when you embrace, for example, integrated services approach. Is it possible for the other participants to mute?
Sorry, Paul. I think we muted all. Please unmute.
Sorry, I think I had been muted.
Yes, now you can continue.
Okay. Okay. So saying that we need to embrace that a sectoral approach and also integrated services approach, whereby whenever we're providing services, we focus on the whole person and offer services that are able to address all the needs of the adolescents being targeted. And the final characteristic here, we're talking about, therefore, about the adolescent-friendly services. It's very, very important, therefore, that whenever we are targeting adolescents with services, we are providing services in a friendly manner or a friendly environment. Sometimes we keep on referring to youth-friendly services. Yeah. Therefore, we are saying that for a health facility to provide SRH services that are adolescent-friendly, the services must adhere to some principles. I'm going to discuss the principles. And saying that all these surround about issues of what? Competencies of the staff, quality of the services delivered, okay? And all this, the impact on the adolescent's decision to seek the services or even come back for more information and services. And these principles, as per this diagram here, sorry guys, I hope my screen is now moving. The slides are moving. You're able to see whatever I'm talking about currently? Please just confirm.
Yes.
Okay. So there are 5 principles of adolescent-friendly services. So look at this diagram. The adolescent is at the center, being surrounded by all these 5. Number 1 is acceptance. Number 2, accessibility, or they must be accessible. 3, effectiveness, equitability, and then appropriateness. In terms of accessibility, we're saying that the services must be accessible in terms of what? Cost. They should be free or affordable for adolescents. We know that cost or pricing is a major barrier towards seeking healthcare services, particularly SRH services amongst adolescents. And we realize that most of the times, the kind of adolescents you're talking about here might not be employed, might not be having an income, and therefore might not be enabled economically or financially to be able to pay for those services. So if we are aiming at having an effective or successful intervention, then the services must be either free or affordable so that adolescents are able to come in for them. The facility has convenient working hours. For example, if we have a facility that operates strictly between 8 to 5, and we realize that within that time range, most of the adolescents maybe are either busy in school or maybe having some hassle elsewhere. So we're saying that if we want to target everyone, then at least we should have some flexibility in terms of operational or working hours. That in the case whereby adolescents are only reachable over the weekends or are only reachable or available in the evenings after school, then facilities should also be able to adjust their working hours beyond the normal working hours, that is past 5, or even over the weekend, so that adolescents are able to freely access these services. Another barrier that prevents most adolescents from accessing these services is a lack of knowledge or information. So we're saying that adolescents should therefore be informed about the range of SRH services available and how to obtain them. How do we inform adolescents? We must do proper sensitization, proper mobilization in the community, either through social media or even use of the peer educators. I know as youth leaders, we should therefore be able to share whatever information we have with adolescents. If you know of any organization that is offering any SRH services as a youth leader or a youth champion, kindly share that out in the platforms that you have, the social media platforms that you have with the adolescents, because having that information with you might not be helpful to the other adolescents out there. And you know that that lack of information is a major barrier. So we should inform them in terms of what? Where the facility is located, which services they are offering, and whether the services are free or they come at a cost. Then also, community members' understanding and support. This is another major barrier. And as an organization, for example, we've been battling this for quite a long time whenever offering adolescent services. A number of community members are still not ready to support the idea of, for example, let me talk about those young girls who feel that they are ready, they are sexually active, and they are ready to take up contraceptives, for example. And talking about that, what we call the principle of capability, that when an adolescent walks into a facility on her own and tells the service provider that, you know, based on my age or maybe my lifestyle, I feel that I'm ready and I want to take up a contraceptive so that I don't become pregnant. Yeah, so should that adolescent should be considered for services. So there are certain community members who are not ready to support that aspect of even talking to adolescents about sexual matters. They feel like, you see, we are promoting promiscuity and we're giving these adolescents a ticket to engage in sexual promiscuity. So we're saying that we need proper community sensitization, have dialogues, for example, parent meetups that we've been running, have those parent meetups, have sessions with parents, with community members through community dialogues, talk to them about the importance of sensitizing and educating adolescents on matters sexuality, so that when they have that understanding and they're able to support that intervention, then it will be successful. But as long as they're not well sensitized and they're not supporting, they don't understand the importance or the benefit of sensitizing adolescents on SRH, then it will still remain a barrier and the adolescents will not be able to freely access these services. And then finally is commonality of age or gender. I think I talked about this. Sometimes in most facilities whereby the service providers, there's a big disparity in terms of age, big variance in terms of age and gender, it might act as a hindrance to some adolescents getting these services. The next principle is acceptance. And here basically talks about confidentiality. We want to assure adolescents that whenever they come for services at that facility, their information or their visits will remain confidential, so that we don't have a case of whereby I, as a service provider, having attended to an adolescent at a facility, and then I go out announcing or spreading that information to the peers about so and so, how he or she came for this particular service, she came for, I don't know, contraceptive or STI screening. That will not encourage adolescents to come for services. And then privacy. There are those who want to access services in a more private way, so that they're not exposed to everyone. So also at the facilities, we should ensure that there's that aspect of privacy. When adolescents come in for services, they're not exposed to everyone, and whatever service they are coming for is not exposed to the public or everyone who should not know about it. Value of non-judgmental attitude is very important. We should be considerate and easy to relate with adolescents and with the service providers themselves. we need to be non-judgmental. Don't judge, don't start questioning why that adolescent at that particular age is engaging in that kind of an act, or that's already having sex at that young age. It might be young, it might appear young to you, but to the adolescent, they feel like they are old enough. So we need to remain judgmental and also considerate to their different needs. And then in terms of express service, young people tend to behave most of the time to be in a very busy mode. Therefore, they wouldn't like to come to a facility and be kept waiting in a queue for so long. So we need to ensure that they spend as less time as possible at a facility whenever they come for services. And then also, for these service provision points to be accepted to the young people, they need to be appealing, and the environment also should be clean. Let's try to maintain some tidiness at the facilities. And then finally, adolescents are actively involved in designing, assessing, and providing health services. An intervention will be more successful and will make more sense to adolescents when adolescents or young people or the youth themselves have been involved in the design, in the assessment, and provision of those services. So that when at least an adolescent walks into a facility, they are received by an adolescent. They feel like, this is one of us. And also, when we are designing these programs and incorporating adolescents in designing and planning for these services, at least they're able to share ideas and bring on board ideas that are going to be more practical and make more sense to adolescents. So the other principle is appropriateness. And here, basically it means what? You've heard about what you call sometimes age-appropriate services. Let's have an appropriate package that makes sense to the age category that is being targeted, so that we don't have, for example, you're talking to very, very young girls and talking to them about issues that might not be more relevant to them. So you're saying that we need to be more considerate in terms of the age categories and provide age-appropriate package of services. Then the other principle is equitability. And we are saying that there shouldn't be any provision, there shouldn't be any restriction for provision. There shouldn't be any restriction for provision of services to adolescents. We need to have supportive policies. For example, in Kenya, at least we have the SRHR policy of 2015, which is supportive, which supports at least provision of information and services to adolescents. And then also, for example, the principle of capability. I talked about it. This just means that when, say, for example, a young girl, a 15-year-old or 16-year-old walks into a facility and explains her case out, based on her lifestyle and her sexual behavior, she feels like maybe she's been sexually active and she's ready to take up contraceptives, then she needs to be considered. Then also, it means that adolescents need to be treated equally, given equal care and respect, so that we don't discriminate based on their backgrounds or maybe whatever socioeconomic statuses that they may belong to. Then in terms of effectiveness, here we're talking about the competent providers to offer required services. We don't want to send adolescents to places or facilities to seek services from incompetent or untrained providers. But we should also at least have some guidelines in service provision. The goodness of having at least some guidelines is that it increases the confidence of even the service providers and even the clients themselves. The clients in this case, the adolescents, they'll be able to confidently walk into that facility and seek services. For example, in Kenya, we have the MOH guidelines and these SRH policies. If you go for a service that is not guided by any policies or any government legislation, then it might appear like you are going for an illegal service. So you're saying that at least when you have some guidelines in service provision, whether MOH guidelines, policies, or legislations, then at least it increases the confidence of both the service provider and the clients seeking those services. And then also in terms of effectiveness, we're saying that, you know, when you're dealing with adolescents, is a bit different from when you're dealing with an adult. It might take some more time counseling and providing information to an adolescent to enable them make an informed decision. And therefore it means what? We don't need to have rushed sessions with adolescents. We need to encourage service providers, for example, or even us as youth champions who deal with adolescents in terms of service provision or even information provision. Let's take time, let's be patient when dealing with adolescents. They might have a lot of questions, you know, a lot of fears, based on what? Based on rumors, based on myths, misconceptions out there. So we need to take time to clarify, provide more detailed information to clear all these myths and misconceptions. Because when they walk out of that facility or service provision points without having clarified all those myths, it's still going to act as a barrier to other adolescents. So let's take time and avoid rushed sessions. And then also, in terms of effectiveness, we need to have appropriate equipment, supplies, and basic services. That once a facility, or for example, when you have a youth center, you know, there are a number of government facilities that have youth centers or youth corners. But the question is, are these youth centers effective? Are they operational? So therefore, they need to have supplies, have equipment, and also have basic services, so that we are not referring adolescents to go for services at a youth center, but those services are not being provided. Adolescents are coming in for, say, HTC counseling, HIV counseling, but when they go there, there's no one to offer that counseling. So we need to ensure that at least there are those basic services at those provision points. Yeah, so in terms of the characteristics of effective or successful interventions, these are the 5 major characteristics that I've talked about. And I've also talked about the major principles that define an adolescent-friendly center. So in terms of evaluation now, how do we evaluate these youth-friendly or maybe SRH interventions? Of course, when you're setting up an intervention, you have a defined target audience, you have a defined intervention model package, and then you also have a defined outcome. So with these 3, therefore, in mind, you can be able to evaluate and see whether that intervention was successful or effective. So in terms of target audience, for example, whom are you targeting with this intervention? Of course, you're targeting the adolescents. When you're having that intervention in school, of course, also you're targeting the teachers, the health workers at the facilities, in the community, parents, and leaders. The leaders also make a very, very important contribution to the success of that program. If the local administration is not convinced, if they don't buy in the idea of sensitizing or reaching out to adolescents with SRH information and services, then it may not be successful. So the intervention model here, as I talked about earlier, either you're targeting schools, health facilities, or communities with outreaches. And then in terms of the outcome, mostly these interventions might look at, for example, having an increased use of FP or SRH services. And you see, when talking about SRH services, there's a whole variant of I mean, there's a whole list of services here. And then also you might be looking at reduced teenage pregnancies. So I think that now marks the end of my presentation on designing, implementing, and evaluating effective or successful SRH interventions.
Well,
so unless there is any question, before I move to the last session. Austin?
Yeah, yes, Mr. Paul. You want to take us through the last.
I'm just confirming if there's any question. Or... Yes, yeah, I want to move the last session, unless if there is any question. Or...
I can see no question from any other member from the group. No question.
So so my last session that is going to take very few minutes, and here I'm going to talk about referral and linkages for adolescent sexual reproductive health services. Talking about referral and linkages. And talking about service referrals, when talking about SRH services, there's a whole list of services here. Which services can we refer adolescents for? For example, number one, we have the HIV testing, counseling, and treatment. You know, targeting adolescents, there is STI testing and counseling, prescribing appropriate medications and health products, pregnancy testing for girls. There's also the aspect of contraception, counseling and provision. And here, just to ensure that adolescents are able to get adequate counseling. What you're trying to avoid is this situation of, say, over-the-counter purchases. Girls just going to pharmacies and purchasing these P2 pills, or even purchasing the other oral whatever pills. So I think there need to be adequate counseling so that we don't have cases of just self-prescribed and over-the-counter purchases. And then also maternal health services for the young mothers. We're much aware that those girls who are giving birth at young ages, and therefore we need to ensure that we have proper services targeting these young mothers. So for us to make successful referrals, there are a number of steps that we need to be conversant with. We're talking about referring adolescents for those listed services. And here the first step is we need to identify the problem. You cannot just refer someone without taking time to understand what kind of service they are in need of. We need to identify the problem they're suffering from before we make that referral. What do they need? Identify or assess their problem, their needs, and capacities with them. Now, for example, do they have any impairments or physical disabilities that require additional assistance? Also, you might be referring someone to a facility, but they're not ready to go. They have their own internal fears. How do you assist that kind of an adolescent? Remember, helping someone to get a service does not just end at the point of referral. You might refer, but there are cases also whereby you might need to physically accompany that adolescent to that facility to be able to get services. They might be having their own internal or artificial barriers that prevent them from walking to that facility or service provision point to seek services. Next, we need to identify which organization or agency can meet the identified need. And that means what? That as youth champions, we need to be much informed. We need to be much informed so that whenever these adolescents we are referring come back to us for questions, we are able to assist. have a list of service. Kindly mute other guys that are not presenting. So we are saying that identify which organizations or agencies can meet the identified need. That as a youth champion, in your area of operation, you must be fully aware of all available service provision points. For example, if a member of your group as a youth champion comes to you in need of, say, STI screening, where can you refer that adolescent? So that you don't just tell them, go look for that service, but you're not telling them exactly where they are going. So you need to have a list, do proper mapping of organizations, CBOs, facilities, whether private or government facilities, that can help out in provision of that service, where they are located, and also whether the services at those facilities are being provided at a fee or freely. And then also contact organizations that can provide the requested service in advance, and find out about their services and eligibility criteria. You might go to an organization and they have their own eligibility criteria. A service is not just provided to anyone who comes in. For example, there's a time we were offering services to the youth between 15 to 19 years, but we had our own criteria at our facilities. That only adolescents who came in with a voucher, or we used to call it there's a voucher that they used to be given, that only those who came in with that voucher will be able to get services. So if that information is not clearly given out there, then it means there are so many other clients or adolescents who are going to come in need of services, but will not be able to access that service. So you're saying that even those peer educators who are doing the mobilization out there must be well informed about the key requirements at that facility or organization before they refer in other adolescents to go for services, so that we don't have cases whereby adolescents are going in and being turned away because of not having met the criteria. And then also, we should be able to properly sensitize the adolescent, explain referral to the adolescent, provide information about available services. Let's give them options that when you go to this facility, for example, these are the services available, this is what you can get, and this is what you cannot be able to get from this facility. If you want, for example, service B, you can go to a different facility. For example, and also, how can the adolescent get there and receive services? Keep in mind that the adolescent can choose not to be referred. And there are two cases here. There's a case whereby an adolescent would come to you seeking a referral as a youth champion. And there are cases whereby also you can identify, you can just scout out and realize this boy or this girl needs a particular service and decide to approach them so that you can refer them for services. Where an adolescent comes to you as a youth champion or a referral agent, then it's a bit more easier because you see, it clearly stipulates that this adolescent is already in need of this particular service. But where it is you who has realized after observing that this individual is in need of these services, then either the adolescent will accept or refuse to be referred. Then also, we need to be able to document that consent. There should always be consent. If the adolescent agrees to the referral, obtain a consent from them before the adolescent's information is shared with others. Others here, I'm referring to a case whereby you've already referred this adolescent, and therefore you are calling the referral facility, the facility or the organization to which you have referred this adolescent in advance, just to make them expect this adolescent going for that service. And then also explain, whenever you're taking any information from that adolescent client, explain how that information will be shared between referring and receiving agencies, okay? And also remember to obtain consent from the adolescents regarding which information can be shared. When you're taking, for example, their names and phone numbers, explain to them why all those details are being taken, and also just ensure to assure them that that information is not going to be used outside of the facility or the service provision point. Then, of course, when you're making the referral, provide the agency's contact information to the adolescent. Of course, the adolescents might be well aware or fully aware of where the organization providing the service or the facility is located, and therefore might not need further information. But in all cases, just ensure to provide them with basic information. And here, you might be providing this referral, making this referral over the phone, by email, or through an app. Yeah, we have cases whereby, for example, those of you who have ever interacted with this project that we've done in collaboration with Triggerize, yeah, these ITH projects, there's that app. Yeah, there's an app that they use to refer adolescents. So when you're using that app also, just make sure that you are sensitizing the adolescents and giving them full information in terms of which information you are collecting and how that information is going to be utilized. And then what is also more important is follow-up. Don't just end at the point of referral, at least make some follow-up, because what is your interest? What is your objective? Is this just a matter of referring that adolescent so that they get out of your way? I think your objective, your end result is what? Ensuring that these adolescents get the service, they get assistance, because you've already observed a situation, a need, and you want to address that need. So make a follow-up after referral, follow up with the agency, follow up the organization with the facility that you refer this adolescent to. Yeah, whether the referral was successful, whether the adolescent was able to access that facility and receive the information. Yeah, for example, did that adolescent receive the planned services? What was the outcome? If they didn't receive the planned service, what was the cause? Why were they not able to get the service? Is it that there was no service provider? Is it that there was no, for example, medication? Yeah, or is it that maybe they were charging for the service and the adolescent did not get the money to pay for the service? You see, when you collect all this information, it is very important, and it will help on what? In terms of making or adjusting, making some adjustments to that intervention going forward. And then also, was the adolescent satisfied with the referral process and the services received? So satisfied client's assessment. So assess whether that adolescent was satisfied with that information. And also, as you get this information from the adolescent, also share feedback with the facility that this adolescent visited, because it will help them in terms of making their interventions and adolescent programs more effective and friendly to adolescents. So confidentiality is very, very important. So ensure that while doing all this, any information, any referral forms, whether you're using a referral form or you're using an app, or maybe you're filling this information in a physical file, storage that ensures confidentiality and privacy is very, very important, so that you don't leave that information just open and accessible to anyone who is not meant to access it. So there must be that aspect of privacy, so that we give it ethical consideration. So where can you link up adolescents for services? So you can either link them to public facilities, private facilities, youth centers or NGO centers. For example, we talk about NGOs, marriage stops, clinics across the country. They focus on adolescents and adult populations. So anytime you want to refer adolescents for services, for example, if you refer them to marriage stops clinics, they'll be able to get assistance. Other organizations also, for example, if you look at FHOK, I think they have youth-friendly centers that you can refer adolescents to, and a number of other organizations. So as youth champions, therefore, it is our responsibility to do some proper mapping to ensure that we are fully aware of our environment, we are fully aware of the organizations and groups or centers or facilities or clinics that are offering these services to adolescents. So when you're referring them to private facilities also, just do some background checks to ensure that the service providers there are qualified, they are competent, and they are able to handle adolescents in a more warmly and friendly manner. And also the rates, the rates being charged for the services are affordable to the adolescents, so that you don't just keep on referring adolescents to private facilities whereby they're not able to afford the services. So in all these, finally, just to remind us about values, you realize that a number of adolescents, they have a barrier to accessing services because of what? Stigma and negative attitude towards SRH. Mostly amongst the service providers, the staff at the facility, and even the community stakeholders. Negative attitude and stigma being propagated by the service providers and community stakeholders, for example. Community stakeholders, you're talking about what? Even the parents, even their peers, you know. For example, if you look at the days whereby even just going for a VCT was such a tall order because of that stigma issue. And people used to believe that whenever you walk into a VCT center, you're infected. Even your friends seeing you walking into an HIV counseling clinic is an issue. They start propagating that stigma. So we need to change values. And that's why we normally have a course on values clarification. We call it VCAT. The VCAT is a values clarification and attitude transformation. And this training or workshops, I mean, these sessions, they normally support participants to explore questions. Yeah, just explore, question, clarify, and affirm their values and beliefs about adolescents and SRH issues. Because as I said, sexual reproductive health is still a very, very controversial area that many people are not able to comfortably talk about and openly discuss. Therefore, VCAT is very, very important, because through VCAT, we are able to address some of these values and barriers that might hinder some people in terms of getting or accessing SRH information. So the VCAT sessions are designed to challenge participants to reflect on their own attitudes and beliefs and the outside forces and experience that have shaped them. You know, when we grow up, our mindsets, our values are shaped by a number of things. You know, the people who surround us, the social institutions, for example, the church, the family, the community, all those factors, they shape our social being and therefore also define our mindset and our belief system. So, so through this, we are able to help participants to move towards positive SRH attitudes and close that service delivery gap in clinical and the community settings. So it's kind of a journey. You know? VCAT therefore takes you through that kind of that cultural, just looking at things from a cultural perspective, a religious perspective, a communal perspective, the things we believe in, and therefore be able to move towards positive attitudes towards SRH. And you see, when we have positive attitudes towards SRH, therefore, we will be able to support and encourage service provision and even clients coming. So I think that marks the end of my presentation. I think I've talked a lot. Therefore, I want to end it there and welcome questions where possible. Thank you.
Thank you, Mr. Paul. That was such an insightful session and conversation we had. And for my far end, we've got a question from Odhiambo Nancy. He's asking, if an underage girl asked me to refer her for abortion, what procedure should I follow? Maybe if you can just respond to a question.
Okay, we know that safe abortion services in Kenya, generally abortion is a restricted service. Let me say it is restricted because it is in between. Yeah, it is in between. We know the conditions under which abortion can be provided in Kenya according to the constitution. Yeah, it says what there are conditions. Either the fetus, yeah, there's a risk towards what the fetus or even the mother, or maybe there are some other underlying conditions. But all these must be supported by the law. So, as a referring agent, what the constitution says is that it gives you permission, either as a youth champion or a community health worker, to provide information and also refer. So remember here, you're not offering the service. You're just making a referral. So you're not making a decision at that particular point. Let the decision be made at the health facility. So it's just okay, refer that client to either a public facility where they'll either get counseling, and by the way, not all people who ask for abortion will end up making or getting an abortion service. Some just require what? Counseling, and they'll be able to proceed on with the pregnancy. But after a thorough assessment, either psychological assessment and clinical assessment, will be able to determine whether that girl is eligible for a safe abortion service or not. So refer that client to a facility that is able to provide that service. Okay.
Thank you, Mr. Paul. Hope, Odhiambo Nancy, your question has been answered. And maybe if any other person has got a question to raise, the platform is still open to any other question before we move on to our next presenter.
Hi, everyone.
Hi.
I think as the questions come in, I can start with my presentation and then people can just put in, because I'm seeing also time.
It's okay, Madam Salima, I can just move on.
Okay. Yes. Are you able to see my screen?
We are yet to view your screen. Yeah, it's okay.
You're good?
Yeah.
So my presentation is on gender and sexual and reproductive health rights. Why I wanted Paul to start us off is because you'll realize some of the things I'm talking about are linked to his presentation. So I'll just start with a brief introduction. Gender, there's a difference between gender and sex. Sex is a biological determination of our reproductive organs, whilst gender are social constructs of being male or female. And gender, because it's a social construct, it's something that is assigned to us by the communities and societies that we live in. And it begins right from the time the sex of the baby is known. Simple things like when you tell people, I'm expecting, I'm pregnant, and they're like, is it a boy or girl? And they're already starting to think. They may not voice it, but they're already starting to think, oh, now you have a son, you have somebody to inherit from you. You have a daughter, you'll have somebody to help you in the house. Gender socialization begins right from that time. It's important to note that gender is a determinant of sexual risk-taking or risk-averse behaviors, but not all gender norms are bad. We have good gender norms that will lead to healthy sexual behaviors and unhealthy gender norms that lead to unhealthy behaviors, which further lead to poor health outcomes. The other thing is that gendered attitudes and beliefs increases our SRH risk-taking behaviors. And an example of this is when you have something like the more, as a boy, one of the gendered attitudes and beliefs is the more sexual partners you have, the more of a man you become. As a girl, you should not talk to anybody about sex or about your sexual needs, or you should not tell people, you should be shy, you should not be assertive. So all these are examples of gendered attitudes and beliefs which increase or reduce our SRH risk-taking behavior. So gender programming, there are different forms of gender programming. Gender programming can be exploitative, and these are programs that take advantage of traditional gender roles to achieve project outcomes. We have traditional gender roles, and I'll ask people to give examples from these communities that we come from. And these are programs that they may contribute to the outcome you're looking for, but they're not sustainable because they do not address root issues and they can have significant harmful consequences. So gender exploitative programs, which take advantage of gender roles, traditional gender roles to achieve a project outcome, should be avoided. Then we have programs that are gender blind or neutral. And these are programs that intentionally or unintentionally fail to acknowledge the role of gender in their theory of change. They do not look at how gender affects what time people will seek services. They do not necessarily cause harm, but they may indirectly support the status quo of gender inequality. And gender-blind programs miss an opportunity to address an important determinant that would likely add impact to their programs. So if an example of a gender-blind program is one that just looks at providing contraception to girls of a certain age, it is gender-blind because it does not involve the young men. It does not look at who are the sexual partners of these girls. It is also blind because it does not look at why are these girls engaging in sex. So it's neutral. It is addressing something, the fact that it's providing contraceptive, but it does not look at the reason behind it. Then we have gender accommodating or gender sensitive programs. And these ones recognize and respond to existing gender norms and inequities, and they seek to implement strategies that adjust to these norms. They do not actively seek to change gender norms and inequities, but they try to limit any harmful impact. An example of this is having what Paul was talking about, timing for services. So you have a specific time where it is only the services are open for young boys. Young boys can go to the facility and access services. It accommodates their schedules. It is accommodative of what they do. It's accommodative in terms that they will have privacy. Nobody else will see them. It will only be fellow peers at that time. But it is not sufficient because they do not alter the balance of power between gender roles and norms. And gender is about the power. Gender socialization is about power assigned to the different genders. Then finally, we have gender transformative programming. So gender transformative approaches are those that seek to change our gender norms. And it's important to say it is not looking at negative, only changing, it does not look at changing all norms, but changing negative norms that negatively affect the health outcomes of the community. As I started by saying, not all gender norms are bad. So gender transformative approaches are effective at reaching positive health outcomes compared to awareness programs. So these ones, they don't only raise awareness, but they seek to raise awareness and transform the different programs. So they want to raise awareness about unhealthy gender norms. They raise question on the cost of adhering to these norms. So they raise questions on, if we continue saying girls should not refuse advances from any man, what is the cost of this to the community? What is the cost of this to the girl herself? What is the cost of this to the community? And then gender transformative approaches seek to replace unhealthy, inequitable gender norms with redefined healthy ones. So you work with the young people, you work with the community to redefine these gender norms to what would be equitable now. And it's important to note that gender transformative programs often take an ecological approach. They don't only look at one facet of a person's environment, but they look at home, schools, workplaces, families, health centers, the healthcare providers, what is in the media, what are the government policies in place, what do the different religions and religious practices that we adhere to, what do they say? So they look at everything and look at changing all these things so that it becomes a conducive environment for the young people. So strategies for strengthening healthy gender norms, attitudes, and behaviors in adolescent sexual reproductive health and rights. We need to look at strategies that increase knowledge and awareness about existence of gender norms. And you'll realize that these strategies, you cannot have a strategy that would work in Nairobi. It's not the same strategy that would work in, let's say, Mombasa. And this is because the gender norms in these two different counties are different. So you need to assess for the common gender norms in your community and raise awareness about this existence of these gender norms for both boys and girls. So what are the different gender norms? And these are strategies that you discuss with the community members. As much as we stay in these communities, we are members of this community, it's important to note that we do not know anything. What the older people within the community know is very different from what the younger people know. What men know is different from what women know. So it's different. It's important to get this knowledge from the different community members. Then the second strategy is, once you've increased the knowledge and awareness about the gender norms, increase knowledge about the cost of adhering to rigid gender norms. What are the reasons behind the gender norms existing? If you talk to older members of the community, you'll realize they'll tell you, no, you people, it's the young people who currently do this. For us, what it was, there was a reason behind it. So now with the young people, examine what is the reasoning behind the gender norms and what is the cost to different community members. You have different gender norms. What is the cost to men? What is the cost to women? What is the cost to girls? And what is the cost to boys? And then redefine the unhealthy gender norms into healthy ones. And this is where the older people in the community, our senior citizens, our parents, This is where they come in, because now they will tell you, as young people, you're the ones who say you want to do 1, 2, 3. For us, we used to do this way. So you work with the older people to redefine the unhealthy gender norms, and you don't tell the youth do this, and you don't bring an older person to tell the youth this is what would used to happen. Do it as something consultative. Send the young people to discuss with their grandparents. Send young people to discuss with uncles and aunts, and then bring them back and they discuss, and you'll realize they'll all come back with different strategies. So this creates opportunities for the youth to redefine harmful and inequitable gender norms into healthy and equitable ones. Then increase skills needed to behave in a more gender equitable way. You might have all the knowledge and you can try and change attitudes to support gender equity, but without the correct skills, nothing changes. People will revert back to their old ways. So in a community where girls are told you cannot be rude, you cannot answer people back, then you train these girls in being assertive. It's not being rude, it's just, yes, how do I say no and mean my no? In communities where people fight, you annoy me, the first thing I will do is hit you, and then we talk about it later. Train the young men in resolving conflicts in non-violent ways. So you need to also change skills. And then number 5, strengthen models of gender equality in the learning environment you're creating. Young people learn from what you observe. You cannot be talking about, oh, you need to respect other people, you need to be polite, you need to be assertive, but you're the one who's outside there, you're being disrespectful. So when working with young people or as a young, as a champion, it is act the talk. You need to be able to ingrain this in yourself. Don't say, do as I say and not what I do, but young people learn more from what they observe. And remember, these are things they've grown up observing from a very young age. So you're trying to change things that they've seen from when they were very small. So act in the way you would like them, and pick up also the skills and behaviors that you'd like them to pick up from you. Then we have cultivate empathy. Create situations where girls and boys are able to empathize with each other's experience. Provide an opportunity for the boys to tell you what they feel if they were to live a day in the day of their sisters or their girlfriends, and vice versa for the boys. So they empathize and they're actually able to realize, oh, wow, by the way, it looks like it's something very simple, but this is what actually happens when I refuse to give my sister space I refuse to support my sister in doing household chores. This is what it leads to. She does not have enough time to study. That's why. So provide an opportunity for them to empathize with each other. Then integrate gender into other learning activities and content. Gender programming, it's not only, you can't just teach it one day and expect people to pick up the new norms, attitudes, and behaviors. Integrate it in every other session. If it's in school, do you have healthy gender norms being taught in schools, within the churches, in community events? So integrate it, then present clear, consistent, and equitable messages about gender. Don't have religious leaders talking one thing. You're doing this in schools, you're doing this within your community events. If you do not have clear and consistent messages, then your programming will not work. And then consider alternating between same-sex and combined sex learning groups. So have areas where you can have girls together, boys together, mixed. And this just provides an opportunity for people to share and cross-learning. Avoid unintentional gender exploitative approaches. So avoid activities or practices that may unintentionally reinforce harmful stereotypes about gender. If you're having an activity, don't just say, the girls will sweep the class today. Why? Why can't the boys support in sweeping and the girls go and do something else? So look at how to avoid that. And then consider other forces in the learner's environment. So consider ways that you can complement the curriculum with activities that impact other forces and perceptions of gender. And then finally, use a social norms approach. This is get the students and get the young people to contrast what they perceive to be normal about a certain issue and what is actually experienced among their peers. I think when a girl is having her periods, misses class because she's having her periods, she's just lazy. But then get experiences from other peers. This girl could be missing classes during her menses because she has other underlying issues. Her menses might be too heavy, that she has other fears that, so use the social norms approach. Don't give them experiences that they cannot relate to, but use experiences that the community would relate to. Thank you. So I've just tried to summarize it. You'll realize that Paul also was covering a bit of this, and that's why I was trying to just make it as short as possible and also give an opportunity for questions.
Well, thank you, Madam Salima, for an interactive session. Maybe if any participant has got any question to raise, the platform is still open for any question. While we are waiting for the questions, you are highly encouraged to fill the Google form accurately, kindly, all the participants, and the slides or the presentation from both the two speakers will be shared to you immediately after the session ends. So kindly, any question from any
Austin,
participant? Yes.
We had said that we would share the presentations at the end of all the sessions so that we can consolidate them into one document instead of them having different.
Okay.
So if that is okay, once we finish all the sessions in the coming weeks, we'll just send you one document with all the presentations.
It's okay.
Thank you.
Any question from participants? Well, with no question, I can say that the session
Rogers?
Rogers has his hand raised.
Yeah, thanks so much for the opportunity and for a very insightful session that we've had. That's why you'll see like there are no question based on a clarity of a presentation. But just to follow up basically on gender norms, I've noticed like there's a gap when it comes to age group, because we young people, we tend to have a different understanding and meaning when it comes to issues to do with sexual reproductive health, unlike the elderly. And for this is really affecting young people, because even like when I mentioned like issues to do with the condom, when a young person like this is now a young person coming home with a condom in a bag, and parents are having issues with you carrying a condom. How do we bring in the elderly and changing this narrative of judgmental issues to do with the sexual reproductive health, even reducing stigma associated with SRHR? How do we bring in the elderly so that we, because with value clarification, like there are beliefs, for example, like they tend to believe basically in their culture more than what we are teaching them a bit on value clarification. So how do, because like it's really difficult to change the culture And basically, for those people who have lived long, they have this saying that whatever they see seated, we cannot see standing. So how do we engage them so that we reduce this stigma? Thanks so much.
Thank you, Rogers. And what I'll say is, one, Paul mentioned about the value clarification and attitude transformation. That would be something crucial. And then it's important to note, you cannot change gender norm and attitudes overnight. They have the reasoning. So what was the reasoning behind? And that's where, for me, part one was looking at understand the reasoning behind the gender norms. So it's not something that you can say, but we've kept telling you this. But it is understanding what was the reasoning behind the norms and the attitudes that they currently have. And then now showing them, but this is the current situation on the ground. And this is why we are requesting that and recommending that young people can use and walk around with condoms and everything and have condoms, because then they're protecting themselves. But there needs to be that. And it's a continuous process. And that's why I've said also, don't only approach it like, but we've talked to you once during a community event. Is this the same message that's being passed on through the religious bodies when they go for their own meetings? Is there another? Do you have a champion amongst them who will share this information? Thank you.
Thanks so much.
Yeah, maybe just to add, I think other than having people within their communities and looking at how to change the perspective over a period of time, it's not something that's going to happen once. You need to start from getting to understand, do they understand the challenges and the problems that young people are facing? That's why we are recommending the use of these contraceptive options. So if they understand the problem better, you can get the buy-in from what they want to be achieved. I think that was also made clear in some of the sessions that we've had, and Salim has also brought it up again. Yeah. And then I had a question as well for Salim and Paul, in terms of actually specifically linked to what training Paul had, and I think this is just for clarification and also to guide the youth champions that we have. We know that there's the referral system and there's some services that some of the young people would need, but I don't know what facilities and organizations are around them and are that available. And I know from Mariscope training, you have clinics all over the country. Can you be able, let's say, based on the mapping that we did for this organization, share contacts for specific people who are working in these facilities, so that if at all there's a need in that community and one of the champions get to access those, to meet those people, they are able to refer them?
Yeah, thanks. I think that can be shared because we have a list of all our facilities and the contact numbers, so that can be shared. And also, because I think all of us now access social media, even that information is available on our webpage. If you happen to go to our website, you'll be able to see a whole list of facilities or clinics where they're located, and the contact information is also provided.
And also on social media, Facebook, Twitter,
yeah.
Instagram, yeah, those ones, TikTok,
That's
those ones that young people are on. Yes.
You even have a TikTok account. I didn't know that.
I need to confirm about TikTok, but I know they're on all those media.
But with your Twitter, Facebook, those ones have interacted with you. Or maybe I'm
Okay.
old. Yeah. So, well, those are some of the opportunities and the platforms you guys can reach out and get to know what is happening in those spaces and how can you interact with Marisol. Because at the end of the day, you need people to get the services, and they're offering the services. So you can refer through their channels as well to improve access. So that is all I wanted to clarify. So back to you, Austin.
So thank you, David. And indeed from
I've
both.
also, sorry, Austin,
Yes.
I've just also shared the toll-free number, 0800 72 0005 on the chat. So you can call that number and you would be able to be they would give you directions to the nearest center. And this number you call from anywhere in the country, and they will link you up.
Oh, perfect. And then I can see we have Isaiah, Ochieng, and Telanjeri who have unmuted. Do you have something to share for us?
Yeah. Good morning.
Good morning.
My thank you the two presenters for that educative session. However, my reservation would be in the linkage. Yes, I acknowledge the fact that there is a improved technology, but from the rural setup, we are realizing some challenges in terms of access to phones that can, Android phones, to access online or services online. But the question is for such cases and for scenarios where we don't have youth-friendly centers, because in our setup, for example, Siaya County, there is no perhaps well-equipped center that we can do referral and young people can get comprehensive SRH services. So for this purpose, we have improvised facilities, but again, that are not managed or manned by trained, well-trained personnel who could provide comprehensive services. And two, the people that are currently managing those improvised sites are older people. So young people fear getting to receive services just because as a result of that. We are having practical example or the experience here in Siaya of similar incidences. But now what as our innovation, we identified young nurses and CEOs who would be having interest in SRH, and now those are the individuals who are again in the specific facilities that we refer for services. So yes, we have STI services, STI cases, we have SGBV cases, we have a condom per se, that young people are in need of these services and commodities, but one, erratic supply from the facilities is also a hindrance. Two is the retrogressive culture that people, young people are befriending girls that are within the same locality. So when you are seen going to a facility, then there is a connotation about you accessing the health facility. So perhaps those are some of the cultures that hinder full access to SRH services. So probably as champions, then we need to really work it out and look at the practicability in terms of referral and now access to services in the respective sites. So my suggestion would be, is there a way that now Mario Stops through this initiative can be able to link us up? Say we have one day in a month or something that we are providing that comprehensive SRH for young people, and the providers be young people within a specific area as we move along. So probably those are my suggestions and questions that really need to be considered as we move along.
Alima, Paul, do you have anything to share on that?
Yeah, just some reaction. That was Isaiah. I think, thanks. That was a great presentation. And actually, what he's saying is true. We acknowledge the fact that a number of county governments are still struggling with this aspect of provision of youth-friendly services. We've been having meetings with the CHMTs across all the counties. yes, they have the concept. They have the concept of running youth centers and providing youth-friendly services. But now actualizing that concept is a problem. We've tried. I know we might not be having centers across all the counties. Now, for example, in Siaya, the nearest is Kisumu. But we have some partnership with private facilities under the brand Amua. We're supporting some facilities to provide these services. However, the challenge might be, these are private facilities, and at times we might not control the age categories that they employ in their facilities and whether they are trained. But in terms of provision of youth-friendly services, most of these facilities that operate under our brand Amua, they have been trained on provision of youth-friendly services. And also in some regions, only that you see, sometimes we run projects that are so much dependent on donor funding. We've been having a project called Gates, and for those of you maybe who have interacted with the countries like Trans Nzoia, Bungoma, and Mombasa, this project has been providing services to adolescents and young people up to the age of 21, and those have been primarily provided by our youth-friendly service providers trained by MSK and employed by MSK. So what we've been doing, we've been running those outreaches like what Isaiah is suggesting, which is doable. Is something that we can organize. Even our outreach teams, there are those days that would want to dedicate to maybe just providing services to young people. So I think, Isaiah, we can get in touch and work out how possible that would be, because we have an outreach team that provides services within Siaya County, but these are just services targeting the general population at public facilities. But in the event that we have a specific or a special youth category that are in need of services, I think we can organize and see how better to address their needs. So I think, Isaiah, you can get in touch so that we can plan further. Thanks.
Thank you.
Well, thank you, Paul, for the feedback. Indeed, the session has been great and successful indeed. Maybe if Dave, you've got something to say?
Not really. I think this has been a good session we've all learned, and we are getting actually key insights and action points. So just a reminder to our participants, as we already agreed in the first session, we'll be doing a report of the lessons that you've learned all along and how some of the ways that you're going to apply these and areas that you feel like you can engage with MSK, Agriculture, and our team so that we improve access to services. So I hope you guys are taking the points and following through. Then for the Google Form feedback form that is done for each and every session, the last 2 sessions we've sent them out, they've not been so much positive response. So it's like you're not responding, or rather you're not following through, which will be the good thing. So we sent the form here in our chat box, but at the same time, we'll send it on email again. I see some people have challenge accessing it from the Zoom meeting room. So please ensure you respond so that we get the feedback, find a way to improve, and even to ensure that as we continue building capacity and driving this agenda, we know what works best, what doesn't work, and how to improve on it. Some of the insights that you're sharing are critical. Like when you say challenge of having youth-friendly services, then the question would be, how do we ensure we can be able to have youth-friendly services being driven by young people? Maybe you guys could be the next cohort of youth service providers. So those are some of the insights that are important. So keep them coming, share your feedback, contribute to this agenda, and actively participate in the meetings that you've done today and in other sessions. So that would be a good one for us. Then the last request that I have, maybe you guys could turn on your cameras. Austin, I believe you're working from a laptop. You could take a picture of the same for all of us to capture just the experience that we have here for reporting purposes as well. Thank you. And thank you so much, Paul and Salima, for bracing the weather and being here with us on a Saturday morning when it's been raining in Nairobi. Really appreciate it.
Maybe if we can just turn on our cameras. The participants, kindly. All the participants, kindly.
Hello, Austin. Good morning. I'm on kindly, but my front camera has issues.
It's okay.
Thank you.
Dave, you can help with taking the screenshots. Well, I am also working on my part.
Unfortunately, I'm using my phone, so I might not be able to. You can use the snipping tool from your end.
Okay.
No.
I'm also using my phone, but I'm also using a laptop here, but I'll just try to do something here a bit.
It's okay.
Just have your cameras on. Here we go. Here we go. Yeah, here we go. Have your cameras on for the last session, for the last week I'm taking. I can see Mudoni, it's okay. Yeah, thank you so much. Thank you so much. It's okay.
Perfect. Thank you so much, everyone. Have a wonderful weekend ahead and make the best of the lessons that we plan together.
Thank you all. Thank you all.
Thank you so much. Thank you so much for the resourceful information. Good day. Hi, Salima. Good day.
Thank you, guys, and enjoy your weekend.
Enjoy your weekend too, Mr. Paul.
Okay, bye.